Good morning, you guys. I am here with the PT on Ice Daily Show. It is Tuesday, January 22nd. I'm live on Facebook and live on Instagram, so I'll do my best to look at both cameras. My name is Dr. Sarah Haran. I'm coming at you live from Seattle, Washington. It's 5:30 a.m. here. And I am here to talk today about all the need to knows of hip impingement. And we're going to get into the weeds on some different exercises and stuff down the road. We'll make sure to let you know those dates as we approach them. But today we want to talk about sort of where we land in the treatment of these patients. So before we get started, I want to just highlight that we are just entering our second week of the first cohort of the Out of Network series through ICE. And if you guys are interested in joining us, the next cohort is in April. And after that, it will be in July, and we're just going to have a blast. So if you have any inkling that you might be interested in learning more about going out of network or cash pay practice, please look into those courses because they are filling up fast. Okay, so hip impingement is like my favorite thing to treat. And part of that is because I actually have hip impingement myself. But really, it's because these patients actually do really, really well with physical therapy. They respond really well to our treatments if we are providing them with the right tools. So recently I listened to a podcast that Jeff did with Dr. Mike Ryman and learned a couple things that I thought were interesting, alarming. First thing that I learned is that in the 1930s is when the theory evolved regarding bony impingement of the femur and the acetabulum. So it was theorized in those years that cam impingement, pincer impingement, and combined impingement, which again, we're not going to go into all the details of that quite yet, that those were causes for potentially arthritic changes, labral tears, other bony abnormalities that could cause pain, right? And so what we found over the last few years, after about 100 years of this theory being in place, is that the literature does not actually support that. Okay, it doesn't support that these anatomical variances are actually problematic. The reason that we can say that with some authority right now is that there are no good long-term studies. Okay, so we actually don't have any data to show that people who have surgery for these problems do better than people who didn't. Unfortunately, these patients are probably being over-surgerized at this point. That is a term that I heard from Dr. Ryman, which sort of encapsulates what I've been feeling for years, is that I see these patients who come in and they're super scared, actually. They went to the surgeon, they went to their orthopedist, right? They were referred by their primary care doctor to a hip specialist. That hip specialist often is a surgeon. Okay, they went with a little bit of hip pain. They're usually pretty active, athletic even. A lot of them are high level in their sport. They just had some groin pain maybe they have a little bit of butt pain. It's keeping them from squatting. Maybe they're having pain in their hip width intercourse positions. It can be very benign. Maybe it's just with sitting and driving that they're feeling it. And then they leave that office going, oh my God, I need surgery? Like, this is nuts. And this surgery is no small feat. It's like they're going to shave bone off of my femur. They're maybe going to repair this thing called the labrum. And then I'm going to be non-weight bearing for a little bit. And then this is going to take me a year to get better. So these patients are really, really nervous. And of course, they put a lot of faith in their providers. And if that provider was a surgeon, then they're going to feel like, well, that's the best option for me. If I ever want to get back to my sport, that's what I have to do. So the trouble is that we sometimes don't catch those patients before they've had surgery, right? And so if we're seeing them post-surgically, that's a whole nother game. And we will kind of talk about that, like I said, in later weeks, how to manage those folks. But traditionally, I'm finding that the exercises I'm using are the same, because surgery, if they do have surgery, it doesn't necessarily change the motor patterns that led them into my office in the first place. So it is my theory that motor patterns and incorrect movement of that hip in its socket is leading to the pain, is leading to the actual problems. So when we talk about hip impingement, there is, of course, bony impingement that you can see on imaging. And it is important to give education about that, but it is important to listen to your patient and respect that they're concerned about that, right? So we don't want to just interrupt them and say, no, don't worry about that. Your imaging doesn't mean anything, because to them, that is going to be a long process of understanding that. So what I want you guys to understand is that there's bony impingement, and that can be cam, pincer, or combined. Cam is where the femoral head is typically a little bit more oval shaped, and so it abuts against the rim a little bit sooner. And pincer is where that socket has a little bit more of a bony edge on either side. It's deeper. Okay, and then combined would be if you have both. Now, I call something else functional impingement. And I think that people who have these bony abnormalities can have this, and I think that people who don't have these bony abnormalities can have this. Functional impingement is where, because of motor patterning and because of incorrect or mal-timed firing of muscles, we're getting jamming of the femur up into the socket. Okay, and then that can cause a lot of inflammation and pain. So that's where I want to go today and kind of talk about how we can address that, how can we assess that with people. But I do think down the road, once you're able to sort of have this conversation with your patients, I think it's important to let them know that the rate of surgery for what we're going to call FAI syndrome, femoroacetabular impingement syndrome, the rate of that surgery has increased astronomically over the last few years. So Dr. Ryman noted that in a 6 to 7 year period, they found that subacromial decompression surgeries increased about 800%, where FAI syndrome surgeries increased by 2,500%. That's 2,500%. And that 600% of that growth was from new surgeons. So it's sort of en vogue, I think. Like, the surgeons are probably just interested in it, and so they're learning these techniques. It's an arthroscopic technique. It's a fairly quick technique, so it may be something that is on the rise because of just interest. Well, unfortunately, I always tell my patients, if you see a surgeon, they're doing their best to help you. Of course, like, we all have our patient's best interest in mind. The surgeons are not doing anything malicious, right? But their tool is surgery. So we are trying to do our best for our patients. Our tool is motor patterning, exercise, education, okay? So first off, we need to listen to our patients and allow them to have that moment where they're like, oh my God, look at my imaging, it's so bad, and give them that. Just allow them to have that, because oftentimes these folks haven't sought out treatment for a long time. I've had patients who have said, I've had this for years, and I'm finally coming. I really don't want to have surgery. I've done some research. I don't want that. So now I'm coming for PT, but I know that I'm really bad, And so I think it's important that we kind of listen to them. They're really scared. The typical patient is really scared. So why aren't PTs the first line of defense then? Is it because we're not referred to by the surgeon because their tool is surgery, or by the primary care doc because, again, they're referring to surgery? Is it because we aren't marketing that we know how to help these patients? I would argue that that is a big problem. And through marketing myself, as a hip specialist, and we can talk about how to do that because I became a hip specialist by treating hip patients, right? So I wasn't necessarily highly trained in a bunch of hip con ed and then advertise myself as such. I just said, I really like to treat these patients and I think I can help them. And then they started to come. And now I feel really comfortable with them. So marketing to them is huge. And then I think that finally, unfortunately, a lot of these patients aren't getting good results with PT. So if they do find themselves in PT, they're not getting great results, they go back to their doctor, they say that, and then this is kind of like this snowball effect where then we are not a good solution for this syndrome. Okay, I would venture to guess that probably the non-successful patients that are struggling to find rehab to be helpful are being over-mobilized in the hip. So especially if they have a labral tear, we want to think about the stability of the hip and what that labrum brings to that position. So the labrum, what we do know about the labrum, and we're still learning what it does, is that it creates negative pressure to pull that ball into the socket. So if we have a tear in that labrum and we've lost some of that suction, now this femur is, we can call this a micro instability. This femur has a micro instability, so it's kind of banging around in there. So when we take a mulligan strap and we laterally distract that joint to give them space, because that's what we do with our arthritic hip patients, that doesn't feel good to them because it feels really unstable. Okay, and then all the muscles can go, like don't do that, and then they're tight, and then they feel tight, and we go, oh, well, let's stretch you. You're tight. We learned in PT school that if it's tight, we stretch it. So then we're stretching. And 9 times out of 10, if I take stretching away from that patient, they do better. So I want to talk about why the first line of defense for me is educating my patient to stop stretching their hip flexor. Okay, so I like to use a band to help get them on board with this, to educate them. So if we imagine that here's the TFL from that ASIS to the greater trochanter, and we are stretching that guy behind us, you can see that that muscle length doesn't change very much, okay? And that's usually what they're trying to stretch. But really what they're stretching is their psoas, which is long and beautiful and usually weak, okay? And so they stretch that guy and they bring this leg way behind them, maybe in pigeon pose, or you're doing like couch position with them, and they're over lengthening this really long muscle, and now it's long and weak, okay? So the first thing I want you guys to do is educate them about that and teach them that and get them to just like sit on their hands, do not stretch, try as hard as you can not to when you feel that urge. And instead, we're gonna do Tfl Down Training. So this is a yoga strap. It doesn't have any stretch to it. So you could use a belt or a pillowcase, anything like that. I'm gonna tilt my camera just a bit. Okay. So when I do this Tfl Down Training, I'm gonna lay on my back with both my legs up, and I'm gonna have the patient palpate right at the TFL, okay? And we'll do a little test where they'll march, and usually their affected side will sort of like bulge up into their fingers much more quickly. And sometimes we can educate them like, okay, bring your ribs down. I want you to have a nice core control. Think about drawing that ball down into the socket as you lift. And sometimes that will change it, but oftentimes not. If the muscle is really irritated and overactive, it's not gonna turn off. So we are gonna down train using a bicep curl. So I'm gonna have them choke up on this strap so that it's nice and firm, and then they're palpating, or maybe I am, really thinking about a little bit of a ribs down position, but not allowing them to tuck their butt under. Okay, so we want tailbone down, ribs down. But more than anything, I want them to feel with their fingers, and they're literally doing a bicep curl. Okay, we're teaching the hip that it's safe to go into flexion without our TFL doing the work. Eventually we're gonna uptrain the psoas, but they're not gonna be able to do it right now until that TFL turns down. Okay, so I usually ask them to do about 10 with good control and no firing. If they get firing, they have to start over. And typically they're gonna get it on the way down. Okay, it's gonna try to grip and help. Okay, so we call that Tfl Down Training, and that's a really great one. It's really easy, it shouldn't flare them up because they're not actually using their hip flexor. If they come back to you and say, this is bugging me, then they're doing it wrong. Okay, so we're gonna leave it there because I know that I talked a lot, but I think this was a good introduction to where we wanna go with this. So try that with your patients. Think about educating them about the hip flexor and about how that mechanic really works. Again, if we think about most of these patients, their femur is sitting a little bit forward. Okay, their femur is sitting a little bit forward in the socket, and that comes from seated posture, that comes from standing posture, right? And when we go to stretch that, all we're really doing is pissing the psoas off and jamming that femur forward even more. So it's my goal for most of these folks to get that femur to sink back, but sometimes we can't get there until they just stop doing that stuff. Okay, so if that's what your first session involves, that's okay. You can do some soft tissue work, you can calm them down, you can educate them about all these things we talked about, get them to stop stretching their hip flexors. Okay, let us know if you guys have any questions, and as we said, we'll continue on this journey. There's lots to cover on the hip, but this is a really important concept to understand. All right, guys, have a great Tuesday. We'll talk soon.